we're gonna wait just another minute or so and see if we give other people a chance to join us, and then we'll kick off our time with Dr. Labus this afternoon. So. Missy, you use the word pivot, and Merriam-Webster often retires buzzwords year after year, and I'm hoping that they retire the word pivot this year.
I don't know if the Friends community will let that happen.
Did anybody go to commencement?
I went yesterday.
How was it?
Warm, but it was nice to have everybody in person. It was just really odd being around a group of people.
I bet.
I've watched both ceremonies yesterday and today online, but we'll be out there this evening.
Yeah, I'll be back there today as well.
Yeah. We were in San Francisco the last couple days, and the city was so quiet. And also, we just feel like, so it's kind of good to be here with the city so quiet, but we felt like we were just a bit ahead of the curve, right? Like maybe a bit ahead of the curve.
Missy, I will wait on you to give me a cue, and then I will start.
I think there's no one else in the waiting room right now. We are already recording, so I would say we're ready to go, Blake.
Okay, excellent. Well, thank you, Missy, and good afternoon, everyone, and thank you for joining us for our virtual Rebel Recharge lecture today. It's been exciting to watch this program grow, thrive, and educate our alumni and friends in the virtual environment for the past year. We're thrilled so many of you have joined us today. My name is Blake Douglas. I'm the Interim Associate Vice President for Alumni Engagement, and it's my honor to personally welcome each of you joining us today. I'd also like to give a special thank you and shout out to Renee Rivera-Gelfi, Coordinator for Programs and Events, and Missy Arendash, Associate Director for Programs and Events, two rock stars on my team for helping produce today's virtual lecture. Our next virtual Rebel Recharge, that's a mouthful, is scheduled for Friday, June 18th. And the topic will be 6 stories you need to tell about yourself, presented by Stephanie Balzer, our Associate Vice President for Marketing and Communications in UNLV's Division of Philanthropy and Alumni Engagement. We have a robust schedule of events, both new and familiar, this spring and summer. And I really encourage you all to visit our webpage at engage.unlv.edu/events. For more information on all of our upcoming events. But more importantly, I hope that you will share your excitement about the events that you attend by inviting others and posting on your own social media channels and tagging @UNLV alumni. Our goal is to continue to grow these programs and create fun, educational, and engaging opportunities for all of our constituents. Now it's my great honor to introduce our speaker for today, Dr. Brian Labus. Dr. Labus is an infectious disease epidemiologist and assistant professor in UNLV School of Public Health. He currently leads a team of over 150 student contact tracers and is a member of Governor Sisolak's COVID-19 medical advisory team. So you can tell he's been kind of bored this past year. His research interests include outbreak investigation, disease surveillance, and the use of social media to detect and investigate health problems in our communities. Prior to joining UNLV in 2015, he spent 15 years at the Southern Nevada Health District as a senior epidemiologist, where he was responsible for leading outbreak investigations, conducting disease surveillance activities, and development of public health informatics projects. Dr. Labus was a lead public health investigator for the largest outbreak of healthcare-acquired hepatitis C in United States history. He received his master's degree in biology from Purdue University, a master's of public health degree in infectious diseases from the School of Public Health at the University of California, Berkeley, and a PhD in public health with a concentration in occupational and environmental health from the School of Public Health at UNLV. We're very thrilled to have Dr. Brian Labus with us today to share his research and perspectives for COVID-19, where do we go from here? Please join me in welcoming Dr. Labus. Turn it over to you.
Well, thank you, and good afternoon, everyone. I'll apologize in advance. I have somebody working on my roof, and I'm sure just as I start talking, they'll start working right above my head. So if you hear it banging, that's why. But there's not much I can do about that at home. So I want to talk today about kind of where we're at with COVID and where we're going. And I want to open things up for a lot of questions as well. I want to give a lot of time for you to ask the things that are on your mind about COVID. This is your chance to really ask me anything about the virus, the vaccine, all that sort of stuff. So I want to leave a lot of time for that today. I don't plan on speaking the entire time, but I really enjoy taking questions from the public and being able to explain the things that are on your mind. So the first thing I want to talk about is where we're at right now. We have seen 3 big waves of COVID. The first one started when the pandemic started in March of last year. And by about the beginning of May, we had gone through a big peak and the numbers had dropped off. And we sat there at a nice low level for May and part of June, and everybody got excited. And we started to reopen things, and bars were opening and restaurants and things like that. And then we saw the next wave of COVID hit us. And so basically by about the start of school, about mid-August or so, we were seeing the highest second peak in that second wave. And then those numbers dropped off until middle to late September, which was great. We finally got things a bit under control. We started reopening things again. We had a couple of UNLV football games with in-person attendance. And then by late October, things were taking off again. And then we saw the worst wave that we've seen hit us with a peak right around the end of the year. So we saw things increase over the entire winter or entire fall from late October through the end of the year. And then things finally started dropping off. In January, February, we saw a huge drop off in cases when we reached kind of our lowest levels about the middle of March. So we started to reach those low levels mid-March, and we kind of stayed around there. The numbers slowed down a bit. And by April 12th, we had gone below 5% of positivity rate for the first time in a long time. And that's an important number because that's the number the World Health Organization uses to say that you basically have your outbreak under control. So a lot of our plans were built around having the test positivity rate at less than 5% and a number of other factors as well. Now, the reason we use that positivity rate is it takes into account the number of tests that are actually being ordered. We know that the number of tests drop way down when there is less disease because of that, but also there's also less interest. So people seek care differently. When there's a big pandemic going on and we're seeing the spike, we get a lot of people that test positive just because there's a lot of disease, but we get a lot more people wanting to get tested. So that really skews the numbers, makes the swing seem a lot more extreme. And so we look at that positivity rate. That's the one number I can really rely on to say what's going on in our community. And about a month ago, we hit that level below 5.0. And since then, we've kind of bounced up and down between 4.5 and around 6.0 or so. So right around that 5.0 number. I think we dropped below 5.0 the last couple of days as well. But we're right around that 5% threshold. And it's been really flat, which is the positive thing that we've seen. I think if we hadn't seen anybody get vaccinated, we'd be in the middle of wave 4 pretty severely right now, given the trend of things that we were seeing. But we still could see wave 4, but right now the vaccine has really blunted that transmission in our community. So we've had those 3 big waves, and there will probably be some fourth wave, especially with all the announcements of yesterday. We'll come back to that in a minute. So we've seen those big 3 waves, and now we're at this part where we're kind of low and we're keeping it there. And a big piece of that is the fact that we have the vaccine available in our community, and people have been vaccinated since the beginning of the year. If you look at the data on the Health District website and you look at the data on the State Health Division website, they are slightly different, but they basically tell the same story. In Southern Nevada, we've given out about 1.6 million doses of vaccine, which is pretty impressive considering that we've only been doing this for 3 or 4 months. We started in January with healthcare providers and the people that are working on the front lines against COVID. We really didn't start doing it for the public in general until beginning of March or so. So over 10 weeks, we've really vaccinated a lot of people. We have clinics all over the community. We have our clinic at UNLV, and those things have been, each of those clinics have been vaccinating thousands of people a day. Now, unfortunately, the numbers of people that are getting vaccinated have really dropped off. They've continued to drop off for the past month or so. As the cases have gone down, as people are less scared, and all the people that wanted to get vaccinated in that first wave of vaccinees have gotten it, things slow down because we're now at the point of people who are hesitant to get vaccinated or absolutely refusing to get it. At this point, we have seen different vaccination rates if we look at different ages. So if we look at the completed vaccine percent by age, in our people that are 70 plus years of age, we're about 72% of them completely vaccinated. That right there is going to make a huge difference in the number of deaths that we see in our community. And we've seen 4,300 deaths in Southern Nevada from COVID so far, and that's about 1 out of 4 people that were hospitalized. We've had 16,000 people hospitalized and over 4,000 deaths, and about 250,000 cases reported. So the fact that we've got 72% of our oldest population vaccinated is great. In 60 to 69, it's 57%, and it keeps dropping until you get to the youngest people. In the 20 to 29-year-old age group, we've got about 1/4 of our people completely vaccinated. Under that, it's a lot trickier. We're at 3.19% of people under 20, but one of the big limitations on that was we haven't been able to vaccinate most of those people until recently. We just started vaccinating people in the 12 to 15-year age group yesterday in Southern Nevada because the FDA approved the Pfizer vaccine for that group. So of course, the youngest age group is going to be the one that has the lowest vaccination rates just because they haven't been able to start that vaccine series. If we look at the percent that have been initiated, it is higher. So in that youngest age group, though, it's still 5.5%. So not a lot of people in that youngest age group have started their vaccines yet, but we've seen a lot of people getting vaccinated. In that 70 plus age group, about 85% of people have started. So we've got 15% of people that are in the process, or the bigger concern is they got the first shot and then decided they didn't want to get the second one. We try to put the message out there that the vaccine is a series. It's not a single shot. And if you want to be fully protected, you need to have both shots of the vaccine. Getting one dose and not the second one only gives you some partial protection, and it's not that great. You really need both of those doses to protect you. And so we're trying to get people vaccinated. The county has set forth a target of 60% of the eligible vaccination, or 60% of eligible people starting the vaccination process. That's very different than saying that 60% of people in our community have been fully vaccinated, because it doesn't take into account children. Even though we extended it to the 12 to 15-year age group, there's about 30,000 kids in each 1-year age group in Southern Nevada. So if you look at kids under 12, you're talking over 300,000 kids that just can't get vaccinated. And that's a big percentage of our population right there. We have about 2.2 million people. And so if you have 300,000 people who can't get vaccinated to begin with, that's going to affect our numbers. So when we're talking about that 60%, that was basically set, I think, as an attainable goal, but it really isn't based on the science of what we know about vaccines. And one thing we've talked about the entire time is trying to reach a level of herd immunity. And there's a lot of misunderstanding about what herd immunity actually is. Now, the idea of herd immunity comes from working with animals that are out in the field and they all interact with each other. So that's one of the first big problems. We assume that everybody has equal interaction with everybody else if we're trying to build a model of herd immunity. We know that's not the case. You don't come in contact with everybody in Southern Nevada. There isn't this equal population mixing. You each have your own little groups of people that you mix with, and then a couple people from that group mix with another group and things like that. It's not like an equal mixing. And so that is a bit of the challenge with herd immunity. In order to say we've reached this certain percentage and we now have herd immunity, you have to have that population mixing. For this virus, it's probably somewhere around 70% or more. Looking at the early numbers, we use a number called the basic reproduction number, which is the number of people that the average infected person will infect. And the early calculations said it was about 2.5. When you do the math, it's 1 minus 1 over 2.5 gets you 60-something% of people that need to be immune so that we basically reach a level where transmission is difficult. But we have a vaccine that's imperfect, so we have to take that into account. And then we have to take into account the fact that people who get vaccinated probably hang out with other people who get vaccinated. And people who are very strongly against getting vaccinated hang out with other people that have the same sorts of views. You tend to hang out with people like yourself and interact with them. And so even if we have 70% of our population immune to this disease, there are going to be pockets of people where everybody's protected, and there are going to be pockets where nobody's protected. So we will still continue to see disease transmission, even if 70% of our population in general is vaccinated against COVID. So that is one of the challenges we face. Everybody thinks there's this magic number. As soon as we put that shot in somebody's arm, we hit that percentage and the outbreak is over. And that's absolutely not the case. And I think people will be disappointed to realize that it's not just a finish line that we cross. There will still be some disease transmission. It doesn't completely go away. But that's kind of been a complete misunderstanding the entire time. There were also a lot of people who very early on said, well, I believe that herd immunity is the solution to this. I don't think we need a vaccine. I don't think we need all this other stuff, and just let everyone get infected. And that unfortunately results in hundreds of thousands of people dying across the country. And yes, you can kind of reach those levels if everyone gets naturally infected, but for all other infectious diseases, that's never happened before. We still have pockets of people where that disease continues to spread at a low level and pops up every once in a while. And that's one of the questions we have about the future of COVID. What's going to happen next in terms of the virus? As we get more and more people vaccinated, it will be harder to get continual spread and get really big flare-ups of the pandemic. But over time, immunity does wear off in people who've had that natural disease. So the vaccine provides a much stronger immunity than getting the disease naturally. And so if you've had the natural infection, you're protected for some amount of time, but it wears off. And so as that wears off, you have more people back into the pool of susceptibles, and you can get little flare-ups when there's enough of those people in that status. Trying to figure out exactly how it's going to look over the next few months is very, very difficult. I can tell you in the next couple of weeks, it's pretty easy to do that sort of thing. It kind of looks like now, and you just kind of draw the line out a little further and say that's likely what's going to happen. But months down the road, it's really difficult to say how this is going to play out, because there are a number of factors that we have to consider. First, we have how many people were naturally infected. Next, we have how many people were vaccinated. And then we have all of the behaviors that people have. So if everybody stops wearing masks versus everybody wears masks, that affects the rate at which this virus is going to spread, and that's going to change the numbers. And then there's the other piece that we have zero control over, which is the emergence of new variants in our community. We see these things pop up all the time. You'll see a news story that said, oh, we found the first case of this particular variant in our community. People get really excited about that, and I don't, because I know that before we have it reported, it's circulating for quite some time. Everybody was worried about the UK variant or the South African variant or the Brazilian variant. You know, when would these things show up in Southern Nevada? And I can guarantee as soon as we're talking about them, they've already shown up in Southern Nevada. They're there at some sort of low level. They haven't really taken over, but basically you have a bunch of viruses competing in a population, and the one that spreads the easiest is going to become the dominant strain. So if we get a strain that spreads easily, then that will become our dominant strain. That also affects the number we need for herd immunity, because what it does is increase that reproduction number. So if I'm infecting twice as many people, I now need to have a lot more people immune before we reach herd immunity in our population. The basic idea is that, say I infect 2 people. Well, if one of those people is vaccinated, I can't infect 2 people and the virus can't explode exponentially. That's just the simple math to it. It's a little more complicated that where it actually plays out, but that's the way we look at it. So as the percentage, or as the basic reproduction number goes up, it's just a higher and higher percentage of people that we need to have vaccinated. The one that spreads the easiest is measles. The reproduction number for that is about 18. So we need to keep over 95% of our people vaccinated against measles to keep that under control, which is why we focus so much on measles. Anytime we see a little flare up, we're trying to get the entire community vaccinated. For this disease, we're talking somewhere about 2.5 to 3. Influenza is probably about 1.5. SARS was somewhere in the 2 range. So it's kind of on the lower end of things, which means we can theoretically do it, but then we have the big challenge of how do we get people vaccinated. We have started to see the vaccine hesitancy really show up at this point, because everybody who really wanted to get vaccinated, those that were willing to cut the lines or drive to other communities or things like that, they got vaccinated early on. The ones that wanted to stand out and make sure they got it on day 1, they did that. And now we're at the point where people are saying, well, I don't know that I really need it. I'm concerned about it. I have particular reasons why I don't want to get it, or those that just absolutely refuse and you can't change their minds at all. Those are the people that we have to reach now. And it's very difficult to do that because the reasons people have for not getting vaccinated vary quite considerably. Some of those are just historical inequities in our community, and they see these long-term problems that we've had with the way we treat people for centuries, and therefore they don't want to be part of a government program, basically. We have other people that have concerns about safety, or that they have some sort of underlying health problem and they want to make sure that it's not going to make that situation worse. And then you have a whole area of conspiracy theories, people that think there's tracking chips and all sorts of things like that in there. And there isn't one simple reason that people aren't getting vaccinated. So in order to change people's minds, you really have to understand why they don't want to get vaccinated. The only success I've had in changing anyone's mind, I think, is basically talking to them as individuals. I get a lot of messages from friends on Facebook where they say, well, I'm really hesitant and here's the 10 concerns I have. And I basically have to go through each concern and explain, here's the reality of that and here's the actual risk. And a lot of times that will get people to change their minds, but that takes a lot of time. It takes hours with just one person to get them vaccinated. And so trying to do those things at a community level is quite challenging because there's just so many reasons that people don't want to get vaccinated. Now, the last thing I want to talk about is the all the stuff that happened yesterday, which kind of changed everything I was going to talk about today. So we put a mask mandate in Nevada about a year ago. It took quite a bit of pushing to get the governor to do that. We wanted to do that early on. The medical advisor team recommended it. And in his press conferences, the governor said that we had done that, but he was really hesitant to put in the mask mandate because we had seen basically the violence that people faced in trying to enforce that mandate. There was a security guard shot and killed at a store somewhere, and people, minimum wage people working at a Walmart were getting beat up over telling somebody to put a mask on, and he didn't want to put the frontline retail workers in that position. Once we started to see a lot more spread, though, it was quite clear that that was one of the things that we had to do in order to get this pandemic under control. So we've had the mask mandate in place for almost a year now. It was a challenge to get it in place, and I'm impressed that we've stayed with it that long when other states have backed off of it. And the states that didn't have the mask mandates have had much higher rates of disease than those that have. So the analysis we've seen early on of the mask mandate shows that they are generally effective in reducing disease. So there are a lot of positives that go with it. So CDC has put out new guidance as of yesterday looking at wearing masks. They've done this a few times, and this is the most recent set. First, they were talking about what can you do if you've been vaccinated. And they said, well, basically, if you've been vaccinated, you could get together with other vaccinated people and you don't need to wear masks and you don't need to socially distance. So if you want to have friends over for a party at your house and everybody's vaccinated, great. You can basically act as if COVID doesn't exist. It's kind of a wonderful thing to think about. If you start to add unvaccinated people into that mix, that changes everything and you have to wear masks and you can't act like COVID doesn't exist. Well, with kids not being able to be vaccinated, as long as you have kids at that party, all of a sudden you have to wear masks, you have to do all those things. So that's been a huge challenge. I heard a lot of parents very upset saying, well, the CDC hasn't considered parents. Well, yeah, they have. The problem is the vaccine just wasn't licensed in children yet. So that was the first part of it. And then the next thing they looked at was, what could you do outdoors if you were vaccinated? And these are just common sense sorts of things. If you're outside by yourself with a few friends who are vaccinated or something like that, you're exercising, riding your bike, walking, whatever, you can absolutely do those things without a mask. And that's because you've been vaccinated and the risk is going to be less because it's an outdoor environment to begin with. So I think everybody was okay with those things. And it wasn't a major shift in what we were saying in a lot of different places. The indoor gatherings of people without masks, that was a little different. But the whole idea of if you're doing things outdoor, keep the group small and have vaccinated people, everybody was kind of on board with that. It wasn't that big of a deal. And then there was a lot of pressure to say, okay, what about everything else? So yesterday, the CDC guidance came out that said, if you're vaccinated, you don't need to wear a mask when you're doing indoor activities. If you aren't vaccinated, you still need to wear a mask when doing those indoor activities. This doesn't apply to transportation. It doesn't apply to healthcare settings. It applies to going to stores and things like that, where you have kind of incidental contact with other people. But if you're vaccinated, you can go without the mask, which scientifically makes absolute perfect sense. You are not at risk of getting the disease. If you do get the disease, you are at very low risk of being hospitalized or dying, and you are not at risk of spreading it to other people. And if you're not vaccinated, that's why you wear the mask, because you have a higher risk of being infected or infecting others. The problem is the science doesn't necessarily translate easily to public policy, because if we want to set this up for a particular business, how do you know who's been vaccinated and who hasn't been vaccinated? We don't have the vaccine passports everywhere where you have it actually tied to your vaccine records. You can go on Amazon or pretty much print a card off the internet that looks like the vaccination card, and you have somebody at the door just looking at little paper cards to verify that. But of course, they don't want to be stuck in that position of having to verify the vaccination status of every person coming into the business. The way we've set up things in Nevada, we've said we'll follow the CDC guidance. And so unfortunately, that makes this new CDC guidance kind of the rule in Nevada. So people are going to be able to walk around without masks, and we have to sort out the unvaccinated from the vaccinated. There is absolutely no way to do that. We have 40% of our population or so fully immunized against COVID. But I bet if you went out to the Strip right now, you would see way more than 40% of the people not wearing masks. People are still going to go out and do those things. It's based on the honor system, unfortunately. And we've seen how people have acted over the last year when it comes to masks and vaccines and those sort of things. There's been a lot of dishonor. People are willing to say they were vaccinated if they weren't. They refuse to get it, refuse to wear the mask, and they're going to cause problems. But it makes it very, very difficult to enforce. And I think this is the problem public health faces every single day. How do we balance science and politics? How do we make sure there's a good balance of protecting people and allowing businesses to reopen? Unfortunately, with this most recent guidance, it's been a huge headache for every one of us in public health because it just is not easy to implement. We either have the option of saying, all right, everybody has to wear a mask, or saying just the vaccinated people do, which essentially means nobody has to wear a mask. We pretty much repealed the mask mandate by doing that. We will still see people wearing masks, but my guess is those most likely to wear masks are the vaccinated people who've done those things all along and have no problem with wearing masks. If you have people who are very much against wearing masks and very much against vaccination, they're going to be walking around without a mask and without a vaccine, and there'll be no way to tell who those people are. And so after that announcement yesterday, the casinos started talking about what they're going to do, and the different casinos have made announcements that if you are vaccinated, you don't have to wear a mask inside the casino, which is great. It makes perfect sense, but it's that honor system that's going to be the huge challenge for us to put in place. And I would expect that we will see some sort of bump in cases as a result, especially among unvaccinated people. Vaccinated people, we've seen a little bit of breakthrough disease. In Southern Nevada, we've had 250,000 cases reported, and I think the last report from the health district had 132 people who had been vaccinated and got disease later, and most of them were asymptomatic and they had no symptoms at all. So we're at the point now where everything has just kind of changed overnight. We went from having this full mask mandate to essentially not having one. And now we have to figure out what to do next. We started talking about what do we do with UNLV? How do we change things on campus when it comes to masks? Now, the CDC has said that if you're in large gatherings, if you're outdoors at a concert or festival, you should still wear a mask just because there's so many people in close contact. Well, we have that once an hour when classes get out on campus. You have thousands of people walking around on campus around each other. And so that's something we have to consider. Do we want to still require that people wear masks when they're in those outdoor settings just because there's so many people walking around in close contact? We also have the challenges of how do we have in-person classes if we're trying to put all these socially distanced steps in place. Having desks 6 feet apart just doesn't work for most of our classrooms. So if we do that, we can't have all of our classes in person. So it's been a huge struggle to figure out what to do. And this just added a brand new layer of complexity to it yesterday. We were talking about what to do as we saw the governor's guidance come out, and we started talking through it, but we don't have an answer yet. So for those of you on campus, I can't tell you what it's going to be. It's something that we're trying to work through and figure out how best to both protect our people and follow the governor's mandate that says, you don't have to wear masks if you're vaccinated. The thing I want to end on is basically what we've done on campus for COVID. And we've taken the same steps everybody else has. We've had our social distancing in place for longer than a lot of the state requirements. We put our mask mandate in before the governor required it. We've taken things very seriously early on. We switched to online classes. The ones that were in person were really spread out. And I'm quite proud of what that resulted in. I don't want to badmouth UNR, but I want to use them as the comparison campus. In the fall, UNR had their classes on campus, and they were a residential campus, so it's a completely different situation than Southern Nevada. They put out a press release in the fall that said UNR was connected to 1 out of every 9 cases in Reno. So they were serving as a place for people to get together and spread disease and drive the outbreak in Northern Nevada. And that's not surprising considering you have a bunch of people in their early 20s going out to bars, partying, all that sort of stuff, and spreading a lot of disease among the student population, and that spreads out into the greater population. And we saw that all over the country. UNR is not unique in that regard. Every college town is basically, that's had in-person classes, has had problems with the university essentially fueling the pandemic. At UNLV, we are actually doing an excellent job with ours. All the things that we did have resulted in low numbers of cases on campus. We track them in real time. So we have the dashboard on our website. If you haven't seen it, as soon as I get a case from my contact tracing team and we finish it and we add the data to the spreadsheet, it automatically updates. So it's up to the minute data, so everybody knows exactly what's going on. there's some numbers that I calculate on my own, though. One of those is the percent of expected cases. So I look at how many people I would expect in a population of 30,000 students and 6,000 faculty and staff. How many cases should we have every week? And over this entire pandemic, we've basically been at half the expected number of cases in our population. So some of that is underreporting, but UNLV is not driving the pandemic in Southern Nevada. We've done an excellent job of stopping transmission among our students and stopping our students from taking it out in the community. The way I like to describe it is we're not driving the pandemic in our community. We're a reflection of the pandemic in our community because we live all over the community. Our students don't live on campus other than a small number. People live and work all over Southern Nevada, and we just reflect what's going on in our community. But I think we've had a lot of people really take the messages to heart about protecting themselves and others, and we've done a good job of preventing disease transmission on campus and definitely not being a source of the pandemic in Southern Nevada. So that's what I've spent my last year and a half trying to do. And I'm quite proud that we've been able to keep those numbers so low for our community over this past year. And I'm also quite proud of my contact tracing team. I just want to plug them before I finish up here. As mentioned in my intro, I have a team of, right now our contract is for 150 students, plus I have about a dozen graduate students who are running this. So my team is entirely made up of students. I have all of 3 full-time people. Everybody else is a student that works on this team. We have investigated 35,000-ish cases since this whole pandemic began. It started with a handful of grad students who volunteered, and now they're paid positions. We've had challenges recently with, we've given people enough experience and skills that they're getting jobs at the health district and with the state health department and things like that, and they're leaving the team, which, you know, I hate to have to replace people. It was great that we're actually preparing students for the real world and sending them out to go do great things. And that's what I'm proudest about with this team. Between the graduate students that I have leading it and the work that those students have done, it's really been a great experience for me and for all the people that are involved that we've been able to help the community. So with that, perfect. It's 12:30 now, so that gives us the second half of this. I will happily take questions on anything COVID related. If it's something I talked about today or didn't talk about today, I'm happy to take any questions about anything.
Yes, thank you so much, Brian. You are such an extraordinary asset to UNLV and our community, so we appreciate you. As he mentioned, this is a great time to open it up to Q&A. So you can go ahead if you want, drop them in the chat, or if you feel comfortable, you're welcome to come off mute and ask that question directly. There are 2 questions in the chat already, Brian, so I'll go ahead and read that. Aaron asked, are the people who are not vaccinated and perhaps lie about it and then walk around without their mask mainly hurting themselves and putting themselves at risk? Or, you know, could you elaborate on that a bit?
Infectious diseases are different. Like if you don't wear a seatbelt in a car and you get in an accident, you hurt yourself. Yes, there may be some money that we have to pay to, you know, to keep you alive or something like that. We all pay with insurance or something like that, but it really hurts you. With infectious diseases, it's very different because not only will it affect you, it affects the people around you. You have to think of yourself as a link in a chain. The only reason we see outbreaks like this is because one person spreads it to 2 people, and those 2 people spread it to 4 people. So not only are you putting yourself at risk with this, where you could get the disease and wind up hospitalized or dying from it, you are helping to perpetuate this pandemic in the community. So your failure to stop yourself from spreading it to somebody else could literally result in thousands of cases down the road. All it takes is one sick person to go to an event, and all of a sudden we have like what happened at the White House Rose Garden. It wasn't like hundreds of sick people showed up. You had 1 or 2 sick people spread it to a lot of people, and all of those people can spread it to a lot of people. And so it just takes one person to really put the entire community at risk, unfortunately. And that's been the challenge of this pandemic, is getting people to think about not just their own health, but the connection they have with everybody around them, because that's how disease spreads in our population.
Brian, this is Erin. I have a follow-up to that question. Sure. I guess I wasn't thinking just about that individual, but because of the vaccine hesitancy, and some people for good reason, right? They have underlying health conditions, or they don't trust, based on being in the non-dominant culture, they don't, you know, kind of trust things, right? Mm-hmm. But if then they're putting, if they're lying about being vaccinated and they're walking around without a mask, they're putting themselves and others who are not vaccinated at risk. Are they putting those of us who have been vaccinated at risk?
A little bit. because part of it is if this disease continues to spread in the population, you can be exposed to it multiple times. And we know the vaccines are not 100% effective. We've shown that the vaccines work really well. 95% effective is great, but that means 5% of the time you get vaccinated and it doesn't wind up protecting you. So it does put everyone at risk, even if you've been vaccinated. If the vaccine were perfectly effective in preventing disease, it wouldn't, but that residual risk is still going to be there. And they're putting everybody in the community at risk, either directly or by infecting people who will then potentially put vaccinated people at risk.
Got it. Thank you, Brian.
Anna, I see that your hand is raised. So if you want to come off mute and ask your question.
Hello. Yes, Dr. Labus. I've been tracking, I do research, so I've been tracking the COVID surges and the cycles that it goes through. And yes, there's always that problem where we have a cluster because of an event or something, but we're having a surge in India, and then it's now moved to Japan. And as you all know, it's going to come here. We can't really stop it. It's a global, we live on one planet. So unfortunately, India has been seeing a lot of younger patients with COVID. And unfortunately, they don't have the healthcare system that actually we don't really have the amount of oxygen tanks as we realized at the beginning and the intubation devices. Considering younger patients though, are you concerned a little bit that we're not really prepared for this oncoming surge? We're not going to be able to stop it. I mean, let's face it. So are we getting prepared for younger patients? Because these medical devices that are used, the mask, the intubation, other devices for breathing are made mostly for adults, and asthmatic children also have that, but we don't have that much of a supply. And seeing those videos from India really is concerning.
So my first comment about the ages, if you look at the rates of disease in our population, the highest rate of disease has been in the 25 to 49 year age group since this pandemic started. So we've seen it in younger people, and then right behind them is the 18 to 24 group. So we've seen a lot of disease in the younger people. We haven't seen as much need for the advanced care in the younger population because they have fewer underlying health problems. They're healthier, immune system, stronger to begin with, those sort of things. So so we've seen a lot of disease in younger people. It hasn't had the highest death rates, but that's the age group that's driven the pandemic here as well. When talking about what's happening in India, there's one huge difference right now, which is the US basically controls the world's vaccine supply. We paid the vaccine manufacturers to produce it, and we've hoarded all of the vaccine. We're talking about, we're giving second doses to people when Canada said we have enough to give everybody the first dose, and then we'll see what we do about the second dose. And other countries have no vaccine at all because they have nobody manufacturing it, they can't afford to get it. So that's been a huge difference right there. India has a massive population and not the same access to the vaccine supply. They also have different social factors that are coming into play with the way the government has responded to it and mask use and the same sort of problems we have here, just whatever their version of it is. And Japan has the same thing. Everybody has their own cultural issues when it comes to what's going on there. I would expect that there is, we'll see more disease in the United States, but the fact that a lot of people are vaccinated is really going to blunt that wave. And what that'll do is spread it out over a longer period of time, which means the supply chain problems we saw in hospitals won't be as bad in whatever this wave. Even if we see as many cases, it'll spread it out. It'll make it slower. That whole thing we talked about earlier of flattening the curve. That's what the vaccine does in a lot of cases as well. We got really close to the edge of being completely overwhelmed in December, and we got right to the edge, and luckily it stepped back then. I don't think we would see a wave that bad just because of the vaccine. We really put ourselves in a good position in the United States. There's all sorts of ethical questions about that of, should we be talking about vaccinating everybody before the oldest people in other countries have been vaccinated and all that. There's a ton of issues that go along with that. But the reality is we have a lot of vaccine here. We have people that don't want it. We have plenty to spare, and we will be able to control that wave a bit more, I think, when those cases actually start to increase here.
So that control will be managed. I mean, we can manage any influx of younger children. I'm talking younger children under the age of 12. because
Right.
medical devices are
We
different.
haven't really seen kids under the age of 12 need hospitalization. The rates of symptomatic disease have been very low in those youngest kids compared to asymptomatic disease. And the ones who get it tend to have very mild illness. So we have not seen severe disease. And if we didn't see it in the last wave in those kids, there's no reason to think it would show up differently in this wave. It may be a higher percentage of those kids in the next wave, just because we've gotten rid of all the older people. And so you shift the
Right.
numbers around a little bit, just in, you shrink one, you grow the other. But I don't think it would be at the point where our system would be overwhelmed for the equipment we would need for the pediatric side, just because it hasn't played out like that yet. The people I think we're seeing the most problems in is that 25 to 49, just when you have a massive explosion of cases, and we have the adult equipment for them. But even then, that age group has been less affected than the older age groups.
All right, thank you.
All right, we do have a couple questions in the chat. So the first one, kind of a quick one, I think, is did Governor Sisolak lift the mask mandate statewide?
So the answer is yes and no. What he said was, we are going to follow the CDC guidance. And the CDC guidance says that you can go without a mask indoors if you've been vaccinated. So there still is a mask mandate for unvaccinated people in Nevada. A mask mandate that is going to be damn near impossible to enforce, but still that mask mandate is still there. So the mandate is still in place. He did say in his directive that no business is prohibited from requiring anything stricter than what we're saying. We've already seen Home Depot and Kroger and other places, other national chains say we are going to keep our mask mandates in place for the time being. So, so yes, kind of, this is going to be a giant mess as it plays out, just because it really treats two groups differently with no clear way to differentiate those groups.
My mouse went all over the place. I couldn't unmute myself. Okay, sorry about that. Do you think the COVID vaccine is eventually going to be like an annual thing similar to the flu shot?
My guess is no for the annual, but probably we will have more doses, and I wouldn't be surprised to see every 5 years we need to get a COVID booster or something like that. Just like every 10 years you get a tetanus shot. And the reason I say that is we get a flu shot every year because flu changes so quickly. Flu mutates a lot, and flu also gets this reassortment. Basically, it has a segmented genome, and if you get infected with two flu viruses, it can mix and match pieces, and you get a brand new virus. And that happens from time to time. It happens in 2009, and so overnight we had a brand new flu virus that nobody had ever seen before, and so we had to vaccinate against that. Because it changes all the time, we vaccinate every single year. It's not that the immunity wears off, it's the change of the virus itself. We have not seen COVID mutate that rapidly. Yes, there's new variants that show up, but the vaccine still works against them. And we have not seen the immunity wearing off quickly either. So people that are vaccinated, we can say 6 months after vaccination, we still have very strong immunity. And so I'm guessing at 12 months, we'll still have good immunity at least. So I don't know that it would be an annual sort of thing, but I wouldn't be surprised to see that every few years we'll have to get a booster shot for COVID to make sure it's not something that we deal with flare-ups every single year of.
Great. And then Stephen, I see your hands raised, but I'm going to ask the one question in the chat and then we'll go to you. So if UNLV requires students to be vaccinated, do you think they will also require this for faculty and staff?
Well, let me change that to say if NSHE requires, because NSHE has said they're the ones that want to take the lead on this. So it's not a UNLV decision. I actually said, hey, we need to have a working group on this. And I had a bunch of people volunteer the next day, and she said, we want to make that decision. And we said, okay, we're gonna stop talking about it. It's not our call. So there's a huge difference between students and faculty and staff in terms of the way that we do it. There is a law in place right now that requires students to be vaccinated. And all we would have to do is add COVID to the list of vaccines that they have to get. Just like they have to get a measles shot or the meningitis shot in the dorms, things like that. You have to be vaccinated as a student. There isn't an equivalent law for adults in Nevada. There isn't an equivalent law for Nevada employees or NSHE employees or anything like that. So in order to require it for faculty and staff, it's going to be a much bigger process to put that in place. And if NSHE goes ahead and does that without having some sort of legal backing, of course, a bunch of faculty members and staff are going to sue, and then it'll wind its way through the courts, and in a few years, we'll have a decision about what actually has to be done. So I think that's why we focused on students. First of all, they're the biggest group, but it is easier to do in students because we don't have the legal framework in place in Nevada to require adult vaccinations for anything. It's really surprising to hear that, I know, but most states are like that. We don't require adult vaccinations. We don't require childhood vaccinations. We require vaccinations when kids go to school. And that's the way we've been able to do it. So it's possible that we could try to put that in place, but there's going to be a lot of discussion before that. Nobody has said anything about faculty and staff. It's all been students nationwide for that reason.
Great. And then Stephen, if you want to come off mute and ask your question.
Hello, Ken. I just wanted to say, first of all, thank you so much for such clear and concise information. It's very refreshing. I wanted to, maybe you could clear up a question I've had for some time about vaccines. And when you hear the 95% figure, those are from studies that looked at whether people got sick after they'd been vaccinated. But my understanding is transmission was not really required to be studied as part of those grants that they got to do those vaccines. So the only figure I've heard is that something like that is that the transmission rate only comes down about 50%. In other words, even if you're vaccinated, you can still get sick. In other words, you can still get infected, but you don't get sick and then pass it on to somebody else. And so it's not nearly as effective at preventing transmission as it is in preventing sickness.
So when we do the clinical trials, it's easy to look at what percent of people get symptomatic disease. And you compare the vaccinated to the unvaccinated, that's pretty straightforward. Figuring out who's been infected is much more difficult. They would have had to basically test every one of those people every single day with a test that we know misses disease in about 15 to 20% of people anyway. And that's why it wasn't studied in the clinical trials, just because it would have been pretty much impossible to do. So in the clinical trials, they compared symptomatic disease in the two groups. And then when it goes to the larger population, they can start looking at that other question. And we have seen that it does reduce disease. So one thing we know is that if you do get infected, you're more likely to have asymptomatic disease. And we've known for the whole pandemic that people who are asymptomatic spread it less than people who are symptomatic. So right there, just changing you from, if it does nothing but change you from symptomatic to asymptomatic disease, it does cut down the transmission quite a bit right there. And then we have to think of what does it mean beyond that. It looks like some of the studies from Israel showed it was quite effective in stopping transmission as well. But like you said, it is possible that you could have an asymptomatic infection and spread it to others. But the vaccine doesn't have to be perfect for us to want to use it. If it's stopping people from being hospitalized and dying, even if they get sick, then that's something we really want to do. You know, if our entire population were vaccinated, even if a bunch of people still got sick but didn't, or still got infected but didn't really get sick, that would be wonderful. It stops people from having the illness and dying, which is another huge goal of this. So we don't just look at the benefit in terms of how many symptomatic cases it stops. We look at all of those things, and every single one of those, it's been effective to some degree in stopping transmission, stopping hospitalization, stopping death, whatever it is. And that's why we are generally in support of these vaccines, because for all the things that we've looked at, we know they're not perfect, but they do reduce transmission and disease considerably.
Right, but the reason I was asking is because if you're trying to do herd immunity, it's only the transmission rate that counts. And so if you're not at anywhere near 95% reduction of transmission, then the number of vaccinated people you have to have for herd immunity is much, much higher.
Yeah, absolutely. And that goes into when you go from the when you're doing the calculations, you can build those things into it. And we do that in a lot of our models. But right now, we're not even close to what we would need with 100% effectiveness with the vaccine. I think we'll be, the other thing that we don't have really built into the models very well is what percent of people in our population have been naturally infected and are immune, at least for some period of time, because we're saying we need X percent of people vaccinated. But we know there are people walking around that were naturally infected who are immune that contribute to that herd immunity, and that's not part of it either. Plus, we also don't know the exact number on the reproductive numbers. The early studies were a bit all over the place. 2.5 was kind of the middle of what they found. We've learned more about asymptomatic disease since then, and then we added the variants to it, which increased the numbers. So we don't have solid numbers for most of the assumptions we put into that equation. But at the very least, we know we're way below where we need to be right now to reach that level.
Well, if we never get to herd immunity or even close, does that mean we're just going to sort of be in the situation we're in now indefinitely?
Well, at a certain point, you get a large proportion of the community naturally infected. And so you get to those levels where there is very little transmission. So if half our population gets vaccinated, we will still continue to see disease in the other half of the population that's unvaccinated. But at some point, a huge percentage of them will be immune because they got disease naturally. And that really controls disease quite a bit in the population.
Okay, thank you very much.
All right, we did have another question drop into the chat in regards to the new CDC mask recommendations. Is it really safe for a fully vaccinated person to not wear a mask when exercising indoors, especially, maybe a high intensity workout?
So the concern we had with indoor exercise is that you're breathing heavily, and it's not that you're sucking in a lot of air, it's that if you're infected, you're putting out a lot of air. We had the same concerns with people that are singing or praying in large groups. We've seen a lot of exposures in religious ceremonies and things like that. And so the risk isn't really to the person, it's to the people around you. So CDC has said it's safe to, if you're vaccinated, to be in all these other areas, to go out and do these things. So the risk really isn't to you. The concern would be an unvaccinated person just expelling a lot of the virus. Even with the high intensity exercise, it's still considered safe by CDC to not wear a mask when exercising indoors.
Well, there goes my excuse for not going to the gym right now. I'm not a big fan wearing it while working out. I'm already out of shape and breathing hard. I don't need. One question I have is, so let's talk a little to the people that potentially contracted the virus last year, right? And went through that journey and then vaccinated, in this time, in this coming, would they be like uber immune? Like what does that look like in regards to?
It doesn't really look like it gives you superpowers or anything like that. The problem is that first exposure, it's not the strongest exposure that your immune system responds to. The vaccine is a much stronger, elicits a much stronger immune response. And so it may be like they kind of had a second dose, but one of the problems is if you had a year ago, a lot of that immunity has worn off. And so you weren't at a great position to begin with. Even now, if you get infected, we say you can get vaccinated as soon as you were out of your isolation period. So, 10 days after you were infected or had disease, you could go get vaccinated because it's just a so much stronger immune response to the vaccine than it is from a natural infection. They might be slightly less likely to get it then, but I don't think it's enough to really make a huge difference. The vaccine is really what makes the difference.
Thank you. So we have a couple more minutes, everyone. This is the time. I mean, we have, an amazing resource here. So ask away. And I see your hand just went up again. So go ahead.
Just one more question here.
Sure.
Is there any plans for a COVID hub where COVID long haulers can access and see, because their doctors are not able to say anything about what the symptoms and the recurring medical issues that they have after COVID? Even some people are, even after a year of having it, are still having. So is there any plans for a COVID hub to be?
I know there are studies right now trying to get that basic data. And I can't imagine if we know those things, we won't put it in a place where it'll be readily accessible to people. I think the challenge we have with the COVID long haulers is that they really have a number of different syndromes. We kind of group it into this thing that COVID kicked it off. And for some people, it's neurologic. For other people, it's respiratory. You get a lot of different things. And each one of those really has to be treated separately. So all the information we have, we definitely want to have in a place where physicians can have it to treat their patients. But I think right now, one of the problems is figuring out exactly, is it COVID? Is it something else that's just coincidental? And what do we do about it in that case? And we don't even have that basic knowledge. So unfortunately, we don't have too much to put together in a hub yet, but I can see that would be a useful thing. I don't know about specific plans for it, but I can't imagine we wouldn't do something like that, especially when you're talking about the tens of millions of people that have been infected with this nationwide, and people that will continue to have symptoms for some long periods of time, potentially after that initial infection.
All right, thank you.
We do have some more questions dropping in the chat. So you pointed out that the new mask guidelines are not enforceable. I think the reason behind it was to find some way to incentivize people to get vaccinated. Can you think of any better ways to incentivize the reluctant people? I know Ohio's given away a bunch of money.
This is a huge challenge. We've talked about this a lot. Do we just want to pay people money to get the vaccine? There's some ethical issues with doing that because it's a emergency use authorization approved vaccine. It's not fully licensed. And so if you give them enough money, it essentially would overcome their free will potentially and push them into doing something they may not want to, especially if they're very low income people. So there's some problems with the financial side of it. You know, we can give out free donuts at Krispy Kreme and things like that. That's probably not enough to get people. I think the problem with using this to incentivize people to get vaccinated is they don't have to get vaccinated to have the benefits of it. All they have to do is claim that they're vaccinated. And that's really been the huge problem. If I had a great way to incentivize people to get vaccinated, I would absolutely be behind it. I think all of us in public health would. This is a problem we've faced for a long time, though, with childhood immunizations and flu shots every single year. If we had the solution, we would be using it. I just don't think we have that solution. We don't know what works, and what works for one person doesn't work for the other. And so it is quite a challenge to deal with this. I wish I had that answer, but I really don't.
And then another question here, if someone got the first dose but didn't get the second dose yet, is there any change in effectiveness if there's a longer gap between the first and second dose, longer than the recommended 3 to 4 weeks?
So we say 3 weeks or 4 weeks because that's what was tested in the clinical trials. We didn't test to see what happens with 5 weeks, 6 weeks, 7 weeks. From the data that we had, CDC said you could go up to 42 days. So you could go 6 weeks without a problem. The guidance from CDC says, even if it's been longer than that, give people the second shot. We just don't know what that means until it happens to a bunch of people because we're not recommending it. But we have to look for those people who don't follow the recommendations for whatever reason. I'm sure there, if you had some sort of health issue in between, completely unrelated or whatever, you got a car accident and just weren't able to get vaccinated, whatever it was, that we basically have to look at that data after the fact, and we'll be able to change it and say, hey, 6 months out, second dose is still perfectly fine. Or, well, if you don't get it within 4 months, you got to start the series over. We just don't have the data to support that yet. So it's hard to say exactly what that length of time is going to be.
And then another question in regards to, curious about the CDC V-Safe. I signed up, but I'm wondering if my I feel fine answers actually help the data. Will I continue to get health check-ins from the CDC in the future?
I got my first dose I think it was like the 5th of January, and I got a V-Safe update like a week ago. So they are doing them, months out. They are following it for quite a while because they want to look for those long-term problems. Really what they're trying to do is identify people who had the adverse events. So the fact that you say, I feel fine, makes them say, yeah, we checked with somebody and they didn't report any adverse events. One of the problems we have with our adverse event reporting system is that it only gets reports from people who have the adverse events. It doesn't, if 90% of the people don't respond to it, we don't know if they all had problems or none of them had problems. And so this does fill in some of that gap. Really what we're interested in, the people with the serious problems. But from this, we can say, well, we looked at the data and 90% of our respondents said, I feel fine at 1 week, 2 weeks, 5 weeks, whatever. So it does actually help because it fills in a gap in the data that we just don't have another way of understanding.
Great. I think we probably have time for one more question if anyone's really burning out there. If not, that's okay. All right, well, join me if you're familiar with the Zoom features of reacting. Let's show Brian some love. Thank you so much in this virtual space, right? These are our rounds of applause now. So thank you again for taking this time. And just to remind everyone that the UNLV Alumni Association is trying to program throughout the year. And I encourage you to visit our website, which I just dropped in the chat, engage.unlv.edu/events for more events similar to this. Our next Rebel Recharge is June 18th, but we're offering a lot of other opportunities too. We have a new summer book club that's going to be starting. So I would encourage you to join us for that and look out, actually, sneak peek, you don't even know this yet, but we are here with an honoree as well. Dr. Brian Labus is going to be the School of Public Health Alumnus of the Year. And so more to come on that around homecoming. So we're very excited and just wonderful. So thank you all again. Enjoy your weekend. Be safe, be well, get vaccinated if you haven't. Take what you've learned here and do with it what you will. So again, have a wonderful weekend. Thank you, Brian.
Thanks for having me.